WPM Martinsburg and WCST Berkeley Springs, a WVRC media station. We're proud to live here too.
Welcome to the WVU Health Sciences Center on the campus of Berkeley Medical Center. Our conversation tonight is Post-Pandemic Healthcare, a discussion of growth, stress, and civility, presented by the Stubblefield Institute for Civil Political Communication. Our moderator for tonight is Hans Vogel.
Healthcare leaders and voices from the community who will, in just a few minutes, start to unpack how our healthcare system has changed through the pandemic and address some of the challenges that we are experiencing today. During the discussion, you in the audience will have an opportunity to ask your questions directly to our panelists. Our moderator, Hans Vogel, will give more instructions in a few minutes on how to do this. Those listening in on the radio or online can ask their questions through the Stubblefield Institute's Facebook page. If you are not familiar with the Stubblefield Institute, we are a relatively new organization that strives to bring quality conversations and civil discourse about our toughest challenges to the Eastern Panhandle and the state of West Virginia. We also provide opportunities for Shepherd students to learn the skills of civil political communication through participation in on-campus and community programs. The Stubblefield Institute was launched in 2019 through a generous gift by Drs. Bonnie and Bill Stubblefield. In the time since, the Institute has hosted events addressing issues such as the Campus Self-Defense Act, freedom of speech, censorship and cancel culture, and how to talk politics in an angry America. The Institute has hosted nationally known political communicators such as Donna Brazile, Mercedes Schlapp, and Ray Suarez, along with many of our West Virginia legislators, including both Senators Shelley Moore Capito and Joe Manchin. Tonight's program was developed by the Community Engagement Committee of the Stubblefield Institute. The Community Engagement Committee is comprised of Ross Curtis, Daniel Bennett, Bev Hughes, Effie Callis, Ed Wilson, and Allison Mee. This group focuses on providing programs with an emphasis on local issues and voices. It is the vision of the Stubblefield Institute that when differing viewpoints are respected and considered in ways that avoid labeling, alienation, and silencing, it can strengthen our nation's ability to solve problems. This is why we are here tonight and why each of you is incredibly important to the future of healthcare in our state. By being here, you are seeking a better understanding of the challenges that we face in healthcare today and being part of the conversation about the solutions to these challenges. Your desire to listen to the expertise, experiences, and perspectives of others is commendable and integral to conceptualizing and creating a healthcare system that works for all of us. I encourage you to be thoughtful in your questions and responses. We aren't here to shy away from the tough conversations, but they do need to be had with respect and with the recognition that we all have arrived where we are today with different life experiences that may lead us to different conclusions. We do not have to agree with one another, but we do need to engage with authentic curiosity and make a good faith effort to examine our own personal assumptions, biases, and stereotypes when considering the beliefs and attitudes of others. I ask everyone in this room right now and those listening on the radio and online to make a commitment to learning something new this evening. Let's set aside any desire to be right and place blame in favor of building a community where we can have these important conversations that lead to understanding and empathy, rather than spinning in circles of rhetoric and righteousness. Through open, honest, and civil discussion of our shared healthcare challenges, we can move together towards understanding the many facets of creating a robust healthcare system and how we can each contribute to creating a stronger healthcare environment that meets the needs of our community and our providers alike. And so, without further ado, I will introduce you to our moderator, Hans Vogel. So Hans grew up in the Eastern Panhandle. I think many of you know him from his time with WEPM. He is a Shepherd University graduate, and he spent about a year living in Petersburg as he began a career in broadcasting. He returned home in 2018 when he became the news director for WEPM Radio in Martinsburg, expanding that role to 2 other stations in the cluster WLTF, and WICO. And he became the host of a local interest talk show, Panhandle Live. He has also worked for Hospice of the Panhandle and has spent the last 3 years as Public Information Officer for Jefferson County Schools. And Hans, I will turn it over to you.
Thank you very much, Ashley. Thank you, everyone, for being here this evening for this important conversation. I'm really grateful to be back on the radio. Sort of what I'm dressed for and what I have a face for is what they keep telling me. But it is definitely important to have these conversations and continue to talk about solutions, because we are all in this together, so to speak. So finding solutions and coming at it from different perspectives, hearing different ideas is critical. Everybody in this room has or will use our healthcare system, and a well-functioning healthcare system is critical to the well-being of citizens, as well as economic development and future growth of our region. In 2020, the COVID-19 pandemic swept quickly through the state and the country, and with immediate impact on all of us, but most especially our healthcare providers and how we would receive care from them. While many of the issues that we'll be discussing this evening are not new, the pandemic accelerated and exacerbated them. This evening, we'll look at some of the lingering effects of the pandemic, our biggest challenges moving forward, and hopefully talk together about some solutions. As you form your questions, consider these issues and how each really has many facets. First, staffing shortages. Shortages of healthcare providers are a national issue, and those shortages are often more profound in rural areas like ours. The Council on Graduate Medical Education reports Strengthening the Rural Health Workforce to Improve Health Outcomes in Rural Communities, published in 2022, showed that the pandemic worsened pre-pandemic shortages, leading to high levels of staff burnout, high turnover, and exposure to infection. Understaffing causes increased workloads, longer shifts, and less flexibility in scheduling, which makes recruitment and retention of providers harder. Understaffing also creates longer waits for patients to get appointments or schedule medical procedures, and lessens one-on-one interaction for those in medical facilities. Recruitment. Urban areas tend to draw potential healthcare professionals away from rural areas due to fewer available resources and lower salaries for providers to apply towards mountains of education debt. Some providers trained in urban areas do not want to return to rural communities after completing their studies. And when rural communities lack certain types of providers, especially specialists, patients must travel longer distances or forego care altogether. And that's a problem, because rural populations tend to have higher rates of chronic illness, higher proportions of elderly residents, and be poorer, causing many to pass on regular health care due to cost. All of these factors put more demand on the system. And lastly, consider the volatility of the healthcare environment today. A lack of trust created through the controversial nature of the pandemic and how it was handled led to increasing incivility and hostility toward healthcare providers. Additionally, residents have expressed feeling that they were treated unfairly and arbitrarily by the healthcare system during the pandemic. All of this leads us to some of the problems that we face today. Our panel this evening will talk to you about some of the issues that we face, how we got here, and then how we will move forward together. I'd like to introduce the panel this evening, starting with Dr. Kevin McLaughlin. Dr. McLaughlin is the health officer for the Berkeley Morgan County Health Department and an ER physician at War Memorial Hospital. Mike Hassing is the chief executive officer for Shenandoah Community Health. Charlotte Norris is a community health worker with the Partnership of African American Churches. Dr. Clay Marsh is the chancellor and executive dean for health sciences at West Virginia University. Dr. Woody Moss is a clinical medical ethicist. Jake Meza is the Vice President, Ambulatory, Post-Acute, and Wellness for Valley Health. And Dr. Michael Londner is the Vice President of Medical Affairs at Berkeley Medical Center, WVU Medicine. First of all, thank you to the panel for being here this evening, and a round of applause for them for being willing to do this. I'm going to give each of them a brief chance to talk about themselves and why they're speaking here tonight. I'll start with Dr. McLaughlin. You have about 30 seconds, give or take. If you hear me awkwardly shuffle behind you, it's probably time to wrap up.
I'll be brief. I'm Dr. Kevin McLaughlin. I'm an osteopathic physician, graduated from osteopathic school in Kansas City, Missouri, trained as a general surgeon, transitioned to emergency medicine. I've always had a interest in public health. Was the health officer over in Morgan County for many years. When we combined boards, I became the deputy health officer for the combined board and have ascended to health officer for the Berkeley Morgan County Boards of Health.
Mike Hassing?
Yeah, Mike Hassing from Shenandoah Community Health, and I've been in this role now for 5.5 years here. Transplant from out in the state of Washington, where I ran a community health center, migrant community health center out in the state of Washington. Been a part of healthcare now for, I think it's 39 years. Started out in healthcare as a part of my tour in the United States Navy as a laboratory technician. And then I went back to school and got a degree in business and accounting, and ended up right back in healthcare again. And I've been there ever since. And it's just a delight to be here tonight.
Thank you, Mike. Mr. Norris?
Thank you. My name is Charlotte Norris. I was asked to serve on the panel because of my role as a community health worker with the Partnership of African American Churches, which is a role that I took on during the pandemic. But I think more importantly, I've had a decade's worth of work working with the Health and Human Service community here in the Eastern Panhandle. But in addition to that, I've been involved in outreach ministry with my church, Destiny Baptist Church, and have worked with many of the area churches and ministries.
Thank you. Dr. Marsh.
Hello, I'm Clay Marsh, and my main role, I guess, on the panel is I help oversee the health side of West Virginia University, including all of the schools, including the School of Medicine, School of Nursing, School of Dentistry, School of Public Health, and the School of Pharmacy. And during the pandemic, Governor Justice asked me to help oversee the state's response to COVID. So he named me COVID czar, and that was not my choice, but nonetheless.
Hi, I'm Woody Moss. I'm a physician fellowship trained in clinical medical ethics, and I bring the lens of medical ethics to look at the issues from the pandemic. I also was very concerned about moral distress and burnout that Hans referred to, and whether or not healthcare professionals had the resilience that was needed. Also, from a public health perspective, the conventional wisdom in public health has been one where you want to use the least restrictive alternative, that voluntary measures are preferable to mandatory measures, that above all else you want to maintain the public's confidence in public health, because if the public doesn't have confidence, they're not going to go along with the proposed interventions.
Thank you. Mr. Meza.
Hey, Jake Meza. I work with Valley Health. I've worked with them for a little over 13 years, and I get a chance to work in the ambulatory world. So I often get asked, what does that really mean? And I joke that it's a lot of the services on the outside of the hospital walls. So many of the services in your backyard, from physician practices, home health services, outpatient pharmacy, urgent cares, telemedicine. So hopefully I get to bring a little bit of that perspective tonight, bring some information forward from that. But also, coincidentally, I served as a city council member in the town of Front Royal in Virginia during the outbreak of COVID. So that was interesting. Also a patient. My kids were patients during COVID. I have 5 children and a lovely wife who keeps me going. So.
And Dr. Londner?
Mike Londner. I'm not entirely sure why I'm here. I guess they couldn't find a 6th person for the panel. So I work clinically as well as administratively for the hospital. I started my training in the great country of New Jersey. And after I finished, I went down to Hopkins and finished my MPH, my MBA, my teaching degree to help augment kind of what we consider collaboration in medicine, trying to cross-bridge a number of different industries and take the pros and cons from our kind of stagnant field and try and bring it into the 21st century, if you will. And this was no better an example of watching the way that people collaborated and innovated during COVID. So we'll bring some of those, hopefully some of those stories to you. But I also think it's important that sitting on both sides of the fence, working the overnight in the department and then coming back the next day and sitting at an administrative table was very valuable for our system, I believe. Sometimes those two things are a little bit separated.
Thank you for your contribution and for balancing out the table. All right, if you look inside your programs, I want to mention this before I forget later on, there is a survey. We would very much like your feedback on this evening's conversation. It helps us steer future discussions and make sure that these are accessible for everybody and that we're getting the kind of information that you're looking for. Later this evening, we will be taking questions from the audience. As Ashley said, we have some questions from Facebook and online as well. When that time comes, if you will raise your hand, someone will bring you a microphone, and you can ask your question of the panelists, and they'll be able to tackle that as a group, or if you have someone individually, they can talk about that as well, and they will have an opportunity, obviously, to follow up on one another's responses. To get us started, though, we have a few questions to set the tone for the evening, and I'll ask each of you to take about 2 minutes to talk about this. Discuss practicing medicine during a global pandemic and how healthcare changed as a result.
In 2 minutes.
Yeah, and ish. Maybe just like the biggest changes. We'll start there. Big picture type stuff. And we'll start, since Dr. Londner ended last time, we'll start with him first this time.
Awesome. Oh, wow. I guess if you could compare night and day, you probably could get the pre- and post-pandemic feel of practicing medicine. I'll speak sort of initially from the emergency perspective. We went from, I think, the busiest emergency department in the state with about 170 people a day to about 250 people a day overnight, most of which were, some of which were worried well, and many of which were looking for information, testing, et cetera, with a staff that didn't change or decreased by 20 to 30% in the first few months of the pandemic. And so we had to make lots of changes. We went from treating 85 to 90% of our folks in beds in the emergency department to treating about 85% either in the waiting room or in the parking lot. And that was a big change in the culture, not only for our providers, but for our patients. But over time, a number of things came out that made it clear that we probably weren't necessarily doing things as well as we could have been in the pre-pandemic period. And so a number of those things that we changed are things we still do today. So there was also good, I would say, innovation during that time. But the kind of access to health care became a very big issue. The resources in the hospital, as I think Dr. Moss will get to, became very challenging. Our ICU became a 100% vented unit, which, you know, we had a 40% vacancy rate prior to that. And so things changed very dramatically overnight. The roles people played changed dramatically overnight, the responsibilities that they took. And quite frankly, the support we got from the community was amazing. We had more folks volunteering and helping us in delivering resources than we ever did prior to the pandemic. So I'll just stop there for now.
Thank you very much. Mr. Meza.
We're going to go round table on these?
Yeah, we're just going to, for these first few, we're just going to...
All right, sounds good. Well, I can't give the practicing medicine response the same as the good doctors here, but I did have the opportunity to work with many of the clinicians. And I'd say, you know, overnight, it was a transition from an everyday focus on the patient to an everyday focus on the patients, the many patients, but then the practitioners and the caregivers. You know, they always take a little bit of a risk as you're taking care of patients. You never know. Somebody has a contagious disease. But this time around, we knew it, and we knew that there was a good chance that many of the patients that they were serving did have contagious disease. And instantly, we had to go from, you know, taking care of our patients to take care of our practitioners so they can take care of our patients. And innovation that was mentioned earlier, thinking outside the box, all the rules that applied before didn't apply moving forward, and how can we take care of more patients with less capacity because of the isolation around it? You know, can we walk outside and take care of a patient curbside in their car? I mean, we've never done that before. So the innovation and the teamwork that had to take place in order to continue to serve the ever-growing need of patients, I think was one of the biggest changes. But I also wanted to mention, you know, in that overnight switch, I don't know if the ER felt this or not, but, you know, in the ambulatory world, you went from, you know, your consistent stream of patients to about a week or two of, like, no patients. Because everybody's scared, everybody's staying home. And then it was like the floodgates opened up and everybody comes flooding back in, and you had that little tsunami effect, and having to deal with what that did to our clinical teams, you know, kind of the mind game that was, and then learning the new normal and moving forward from there. I think those were some of the biggest transitions that healthcare made, at least in the ambulatory front.
Thank you. Dr. Moss?
Yeah. As I was making rounds in the hospital during the height of the pandemic, one of the things that I was most struck by was how much pressure the nurses were under. And I would ask, what's going on? And they'd say, well, we were assigned more patients than we usually carry because we just don't have enough nurses. So I was concerned, and I started calling colleagues all over the country, and they were saying the same thing, that they were short on nurses. We had beds that were closed, and the hospitals were full. Yes, because we had a lot of patients, but also because we didn't have enough staff to take care of all the beds that could have been filled. So as I sort of dug into that, because from the ethics perspective, I'm thinking, well, what is the right way? How should we handle this? And although we say patients are the first priority in everything we do, it dawned on me, if we don't have healthcare professionals to take care of the patients, then we're not going to be able to take good care of the patients. And ethics is all about right and good care for patients. So then I became interested in, all right, what were the issues for the nurses, the respiratory therapists? You know, we were in short staff and a lot of people. And honestly, it was like they felt they weren't listened to, they weren't heard and understood. They didn't feel like people were sitting down and talking to them and understanding their stresses and what their pressures were. And if schools were closed, that meant somebody had to be home with the kids because the kids were home. And if both husband and wife were in healthcare, that meant there was one less person in healthcare. And so I think one of our lessons moving forward, because I think this panel is about how can we do this better next time around, is we need to realize that our healthcare professionals are a precious commodity. I hate to say it that way, but they're precious. I think we all would agree they're precious. And if we don't have our full interdisciplinary team, we can't take the best care possible. So we need to do a really good job of paying attention to the needs of everybody on the team.
Thank you, Dr. Moss. Dr. Marsh?
So I'll take a little bit of a different slant and just talk about at the sort of the larger level what was going on. So we watched COVID start in China and then roll into Italy. And in Italy, people in a very rich part of Italy, particularly older men who were smokers, were dying so rapidly that ultimately they had to restrict the people who could get admitted to the ICU and be given a mechanical ventilator to people under 65 years old. So they then made those decisions because they just didn't have enough equipment to go around. And we watched COVID then move across the Atlantic Ocean to New York. And a friend of mine who was the dean of the School of Medicine, who's a lung ICU guy, which is what I am too. So my training is in pulmonary and critical care medicine. When I was at Ohio State, I oversaw all of the critical care at Ohio State for a while. And he said that they had 285 beds that were all taken with people that were on ventilators. They ran out of ventilators and they had to take tubing and attach 2 people to one ventilator after a while because they couldn't accommodate that. They moved into the Javits Center with more and more people, and people were just overwhelmed, and not only overwhelmed with the moral, ethical dilemma, the burnout, they were overwhelmed with the lack of equipment. And at the same time, we didn't have enough protective equipment to protect the people who were caring for patients. And people are, professionals are people with families, and people were worried about going home. People, took their clothes off when they got home and threw them in a washing machine before they even stepped in the house. Remember, we couldn't find Lysol wipes because people were so focused on that. And I see Tom Thomas, who played a really important role for our country as a major general in military medicine. But indeed, that's what it became. It became military medicine. We were triaging. Before we got vaccines and treatments, we had people that were so sick that we were using bedside cardiac bypass machines. And we ran out of those because we never prepared for the requirement. And people would call us from all over the country, 20-year-olds, 30-year-olds, 40-year-olds, families calling all around the country, begging people to take their family member because they couldn't survive without this really extraordinary life-supporting therapy. And so many people that called, we had to turn down. And we expanded, we doubled our capacity to do that. But as we kept going, the healthcare workers, who in my mind were the heroes, in some ways became the villains for people. And caught up in this political sort of discourse where people, who were tired and overworked and stressed and scared, who answered the bell just like the firemen did in 9/11, just like our police force have, like our military force has. So I look at this as an extraordinary time for medicine. And while we're trying to take the lessons learned, I'll be done in a minute. Thank you. While we're trying to take the lessons learned and be better next time, we saw every system start to crumble because it was under such intense, urgent stress. And so reconstituting and creating the resilience for the system is multiple systems got taxed as one, but it demonstrated how powerful a pandemic that we knew would be coming at some point was, and how we were thought to be the best country in the world to deal with it, and probably dealt with it as poorly as most any rich westernized country.
Only 1 minute next time, Dr. Marsh. All right. Ms. Norris?
Thank you. What I discovered in getting involved with the pandemic, early on you would hear this word hesitancy, particularly as it related to the African American community. But what we experienced in the church communities that I worked with early on was anxiety about getting vaccinated and getting tested. And so there was a great opportunity for us to work together, various churches, to make sure that particularly our seasoned saints, the oldest of our populations, many of us have, church congregations that are older, had a lot of anxiety about being able to get in and get vaccinated. Many of them were not Facebook users, they were not computer users, and we used the old-fashioned telephone, working with church secretaries and pastor wives and staff members to literally go down our church rolls and identify those who were in the age range that could get those early vaccinations. And we were fortunate through the partnership of African American churches to be able to start doing vaccination clinics early on in churches. And we always had an overwhelming, unfortunately, my personal phone, my home phone, and my work phone all became constant ringing for people anxious, looking for how they could get vaccinated. But on the other part of that, and I would always share with the staff in Charleston, we had to assemble a clinical team. And it was very challenging because, again, you all were looking for workers, and ultimately we never really got very many full-time, but we were able to supplement it with part-time staff. But we also had a lot of particularly health workers of color that came and volunteered at our early clinics. And so it just was a real wonderful time for us to work together in the church community to make sure that the oldest of our populations were safe. And I saw we got an email about doing praise reports for the Bureau of Health, and I look at our own congregation at Destiny, which has probably the average age is probably 65 plus, and when we were able to go back into service, probably about 95% of our congregation was fully vaccinated, and we were very blessed that we never had any COVID-related deaths within our congregation. But it took a lot of work. We early on had our own czar. Michelle Barnes-Russell was our church czar within that, and we had a committee, and we worked with Dr. Marsh, who did Bible studies with us virtually. And so, all of those things coming together gave assurance to our members that it was safe to have the vaccine, and the much younger populations where we had the biggest significant issues was trying to get them vaccinated. But our older saints, they were ready and willing to come and get vaccinated.
I like that term, saints. That's Mrs. Norris. Mr. Hassing?
I probably better not pull that over too much further. It's getting a little tight there on the wire. But it's it was very interesting for us in our organization. As soon as the public health emergency was declared, we very quickly learned that many of and Shenandoah Community Health is outpatient services. We don't provide any inpatient services at all. So as you heard about the challenges within the hospital, our challenges were really around trying to provide outpatient care, and many of those services were greatly restricted at that time in just being able to see the most sick of the sick. But we ended up almost immediately recognizing that that the way for us to continue to provide access to care was we needed to start doing telemedicine. And so, and up to that, to the public health emergency, we had had 0 telemedicine visits. The Monday after the public health emergency, we had hundreds of visits that we were performing via telemedicine. So, and over the next couple of years, we continued to make improvements on that. But it's been interesting to see that the telemedicine services has declined back to about average national rates of about 25% or so of our visits are that way. But we also had to innovate in that we started to do curbside pharmacy pickup. So people would call in for their medications, and instead of having them come into the building because we had to restrict building access greatly, we were able to take it out, take things out to the curbside. Our dental clinic ended up being shut down completely. We weren't allowed to provide any dental services because of the aerosols that are generated when they're working with handpieces, and that was just not allowed at that time. So now all of a sudden, as we're trying to screen people as they're coming into the parking lot, we've got dentists, we've got hygienists, and dental assistants out front at the stop sign asking people whether or not they felt they had any symptoms of COVID, and they're directing traffic for us. So the other thing that ended up happening for us is for the safety of the staff, is we made the decision to basically split our staff into 2 groups. So we had an A group and a B group, or some of them like to say A plus and A plus plus. Nobody wants to be a B, okay? Everyone wants to be an A. But we had 2 groups, and we rotated them on a weekly basis. One week the A group was on the next week the B group was on, and that was just in an effort to try to help protect our staff from exposure to COVID. Fortunately, we didn't have a lot of staff that left our employment, but we did have a few of them that decided that healthcare was not for them any longer, and they left our employment. I'm sure that others had that happen to them, but I'm pleased to say that in the end that we didn't lose very many staff, and we're all back together again now and providing services to the general population.
Thank you, sir. And Dr. McLaughlin?
So I'm going to take this as a public health aspect, not as an ER aspect. I think Dr. Londner can speak to ER, and I can speak to that on other things. But as the public health officer, as soon as we saw this coming, as soon as it left China and went to Italy, we started forming a committee because we knew it was coming. But we didn't know in what shape or form and what we were going to have to do. So we quickly learned that we needed to be in the logistics business very quickly, which meant we had to be able to test in multiple areas. So all 3 counties were all the counties were kind of assigned to start testing. Well, I don't know if everyone knows, in the health department we have a clinical team and we have an environmental team. Our environmental team does a lot of the inspections and septics, etc. They do nothing per se medical. Well, everyone became some form of a medical technician, either data entry or what. So in the beginning, essentially food inspections, septics, anything along those lines stopped. Everyone switched to becoming whatever we needed to be done that day for testing, which was, Dr. Marsh can probably speak to that a little bit better, but that was our first assignment, to test, because we didn't have a vaccine. But we knew that if we could find those that were infected and keep them away from others, that we would slow the tide. Was probably the best way of putting it. I can't tell you how many people I personally and everyone else, that the whole team tested in the beginning. We set up at schools. We set up at churches. We set up anywhere we could, literally to have a drive-through to test. We had National Guard there helping us. Thankfully, the governor sent us help because we did not have the staff. We still don't have enough staff. If the pandemic hit tomorrow, we would still need extra people. And I think that's probably one thing that every one of us can agree on. If this happened again tomorrow, we would still need an influx of people, bodies, technicians and people, volunteers to do jobs that just need to get done. And then we had to transition to vaccinations. We started at older age groups, moved down. I can't tell you how many times we were at the Berkeley 2000 Center because it was a large facility and it had a large parking lot because you had to have enough places for people to park so that they weren't on top of each other. So we had to do that. We were doing 1,500 to 1,800 people a day of vaccinations. Berkeley County has 120,000 plus. Morgan County is 18,000 plus. So there was a huge need. So people did whatever needed to be done, but we had to transition to that. And literally all the standard stuff from the health department stopped just to fill that need for the public's safety and the public's benefit.
Thank you, Dr. McLaughlin. If you're just joining us at home, you're listening to the Stubblefield Institute at Shepherd University, the American Conversation series. Tonight's conversation, Post-Pandemic Healthcare, a discussion of growth, stress, and civility, being broadcast on the Panhandle News Network, WEPM Martinsburg, WCST Berkeley Springs. The next topic of discussion has been touched on by a few folks here, so I'd really like to hear the panel's thoughts and maybe some discussion about it. Fear, conflicting information, even misinformation led to mistrust of the medical community. What do you think needs to happen for that trust to be restored? I'll open that up to the floor. All right, Dr. Moss, I see a hand. Make sure we are broadcasting, as I mentioned, so everyone talking to the microphone.
Trust is really important in the physician-patient relationship, any type of healthcare provider. And NBC News did a survey in January of 2022 and asked Americans, do you trust the CDC to handle the coronavirus epidemic? And only 44% said they trusted the CDC. In other words, the majority did not. That was one measure that people pointed to. The second thing was after the primary series, after everybody got the primary series, or whoever wanted to got the primary series, about 10 months later, it was recommended to get a booster because it became apparent that the primary series had waning effectiveness. So the CDC published data, and only a third of people who were eligible to get a booster dose got it. And then as we've looked at the bivalent, Omicron, how many are getting that? That number is smaller yet. So one of the fundamental things, I always teach our medical students and our residents, whenever you're sitting down to talk to a patient, the first thing you have to do is establish trust and build rapport. And we found, and all of these speakers are talking about the tremendous effort that was made. But as public health ethicists have written about how to respond to a pandemic, they say you shouldn't leave this just to the healthcare professionals. You should involve patients. You should involve families. You should involve teachers. You should involve parents. You should involve bankers, economists, lawyers. And so I think one good thing, one wonderful thing about this discussion tonight is that we're having a slightly broader discussion. So if we had to do this the next time around, we might want to organize an advisory group in the state that would get more perspective in a discussion like this.
Dr. Londner? Into the
points.
microphone, please, for the folks at home.
So just a couple of quick points. So at one point in my history, I was the director for the Center for Emergency Response and Refugee Studies, and we did disaster work in 40 different countries at various levels. And one of the things that you recognize very quickly about disasters is that people are very gung-ho initially, and you bring a lot of resources to bear. But then it's the remainder of the time that people kind of go back home and you leave things non-sustainable. And I feel like there was a lot of that in this effort, to your description. So I just bring that to the front, that sustainability and then the ability to re-escalate things if need be. And we've left a lot of vacuums, some because people just are no longer there, and some because we have maybe replaced them with other things. The next point, which I think is super important, trust between patients and providers is really important, but also trust between the providers and the administrators who are managing them is equally important. And as things moved on, I think some of that trust also started to erode in the sense that, do you not realize I'm here with 37 patients by myself? Do you not, of course I do, I just don't have an answer for you, but that's hard to say at 3 a.m. to providers. And so I think those things that you bring up are very important. In terms of rebuilding trust, one of the things that's been really amazing is to watch the kind of community interface. And so we actually introduced 5 or 6 programs with addiction services and with adolescent behavioral health into the community during this. And those things have given more credibility back to the healthcare system than the fact that we have 24-hour day coverage. We didn't lose a single physician. Not a single member of our department died from COVID. Like, we did a lot of amazing things, but those things are the things that the community is now responding positively to. So I would say, to your point, maybe it's not exactly what we thought would be the answer.
Dr. Marsh, then Ms. Norris.
So I think that I'll take on the question about communication, because what happened during the pandemic, at least from my perspective, was that there was not only disinformation, people that had their own agendas and wanted to send certain messages, and people focused on our human drive to deal with threat more seriously than things that are positive. So things that are negative make us much more aware quicker, about twice as much than things that are really positive. But in addition to some sources trying to perhaps be anti whatever it was, vaccines or medication or whatever it was, there was also, I think, a really important set of lessons in the fact that we were basically disclosing information real time, and we weren't editing it at all. So there was so many different sources that even at some points, our leadership team was very confused about what the CDC and the FDA and wanted to do. And I don't think it was because anybody had bad intentions. It was because there was this incredible flood through all these different channels, media channels, social media channels, Twitter, etc., in real time almost, about stuff that was coming out. And some of that changed over time because the pandemic was moving quickly as we saw different variants and we saw the impact of severity for like the Delta variant with the lung problem and people all dying in the ICUs. We were losing a lot of people, and everybody were really interested in up-to-date information. But much of that was not edited correctly. And so what we did is we started to use an evidence-based communication approach that we got out of our Reed Media College, led by a professional who worked also with the CDC during the pandemic, Dr. Julia Frostino, and we learned a lot, and that learning will help us if we have another problem like this.
The messenger matters. I can't say that, give more emphasis to that. The messenger matters. When you're looking at communities who are in fear, they're going to look to trusted voices within their community, whether it's their pastor, whether it's the mother of the neighborhood, whether it's the principal at their school, but they're going to look to those people who they have trust in. And so I think it's really important. There has to be that bridge between the medical community and the community at large, and building those partnerships, particularly during these times. And what we found, and I think one of the great things that the partnership did early on was pull together, because we were a statewide initiative, individuals within their own communities that were those trusted voices. And so I think that's something that we need to really look at in the future as we look at how do we communicate and give messages. It's really important. Like I said, there were conflicting messages, but to be able to weed through that, and at the end of the day, to build that trust, you have to have someone that they have trust in as well.
Dr. McLaughlin?
So I'm going to speak to the conflicting messages because I think the perspective of it is we were learning in real time. So what we thought might be correct today or yesterday, we may have learned that that needed to be modified. And tomorrow, that may need to be modified again. We were learning literally day by day. So when someone was posting or saying or using information from literally days ago, we had learned that that was incorrect or had to be adjusted, which led to confusion by the public, which potentially was used as misinformation. And I really think that goes back to the messaging and goes back to the real time. We're learning so fast and the information was changing so fast that if you weren't literally on the edge of what was happening, yesterday's information may well be wrong, literally wrong. And so when the discussion came around with your patients or friends or other colleagues, you had to be learning whatever was new that day. So I think that probably led to some of the confusion with the information that was being put out.
Dr. Moss?
Yeah.
Yeah,
So
go ahead, please.
I think humility is a really important thing. And I think, to pick up on a couple of points, I think we got out over our skis, if that expression is correct. We were saying things that turned out later not to be true. We may have believed them to be true the day we said them. But, I'm sure we all remember who said, get vaccinated and you won't get COVID. And then I recall that the West Virginia DHHR website one day had 1,000 breakthrough deaths and 10,000 breakthrough cases of COVID. And it became very obvious all over the country. And you alluded to the Delta variant. We had people who were fully vaccinated coming down with the Delta variant. So I'm thinking from the ethics standpoint, humility, transparency, accountability, we don't really know at this point. We hope that this is going to be an effective approach. But I think if we would have lowered everybody's expectations a little bit, right? We all know if you overpromise, you're usually going to end up behind the 8 ball, right? And so I think if we hadn't overpromised as much and people hadn't expected as much, then when it became very obvious that we had an Omicron variant and we had this variant and that variant, and the bivalent isn't working well against the latest Omicron variant. Oh, well, that's because, as you said, we just have all these variants, one after another. So, anyway, I'm just talking about humility, truthfulness, accountability, transparency, and that way the public, at least, we won't lose their trust because they see we're really trying to tell them as best we know and not telling them more than we know.
Thank you, Dr. Moss. Mr. Meza, then Dr. Marsh.
Yeah, I agree completely with Dr. Moss, but let's not forget the environmental factors that were happening around that time. And this is like one of the first times we're being told no as Americans. No, you can't go to the store. You can't go to your favorite movie theater. You can't. Our choices are being taken away, and Americans don't like that. And so, we got the environmental factors, and then we're coming into an institution in our time of need that's trying to set up a structure to keep their team safe and take care of you at the same time. And you're met with that little bit of fear and sometimes hostility as they're trying to figure out how to navigate that. So when you talk about winning trust back, if I were to go back and do some of this differently, particularly in our frontline clinics, I don't think I'd miss the opportunity to staff in such a way that we could over-communicate and comfort people as they're walking in and be able to walk them through the scary process as everywhere else in society is telling them no. We got to try to find ways to give them that yes that they're looking for and let them feel safe as we try to do every day today as we're taking care of patients. But I think it's important not to forget that there were a lot of environmental factors that were stacked against the healthcare system where everybody was pouring into that had already put us on our and losing trust.
Dr. Marsh?
Yeah, just a couple things. One, and I love the comments about trust. We knew from our data at the evidence sort of based communication that primary care providers or healthcare teams were the most trusted source for people during the pandemic, family members, and then people in the churches or other areas that they were members of. I would also say that there is also a important issue that came up, because when we first got vaccines and they were limited, we could not get enough of them. I mean, we even had to protect the vaccines in transport because we were worried that, they might be taken over by people that would want to sell them on the black market, et cetera. So it was kind of a crazy time. And then as things moved forward, we knew that the vaccines made a big impact in all of the data. And one of the things we were able to do, because we were so far down the interconnected food chain, that what happened in Israel and what happened in Europe was really good insight for what was going to happen here. And the benefits they got from the different interventions, and they published them, really gave us a lot of insight about the things that we should do to help save lives and to help people. And I think that for me, what I learned during the pandemic, the governor, whose intuition was to communicate all the time, because of the way that he communicated with the state and the fact that he was really, every day we did press briefs, I think it was a really important part of the reason why, even though we were predicted to have the worst outcomes in the country, in fact, we did much better working together than we were at least initially predicted to do.
Thank you, Dr. Marsh. And Dr. Londner, I'm going to let you have the last word before we go to a commercial break.
Just to pick up on a few of the things that were said, we actually provided bullet points for our folks coming into work day to day, because things were so different. And if you missed a day or two of work because you were at home, and you came back to work, you had no idea what was the medicine of the day, what are you doing, whatever. So there would be an index card that was kind of passed down that everyone would kind of have as rhetoric. But to Dr. Moss's point, one of the things that I'm kind of laughing at us, because we keep talking about how we're going to learn from our mistakes, yet we don't have anyone other than us as professionals sitting at the table. And I used to laugh because I would get up I work overnight, so I'd get up in the morning, and my son, who was at that time in school, a teenager, would then greet me with the information of the day. And he would tell me about COVID so I could bring it to work. And quite frankly, we're no longer like kind of breaks on the system. Before we had a printing press, or before people could read, it was easy to control information flow. Then we had a printing press, and then we developed the radio, then we had the TV. Now we have immediate access to everyone. And the loudest, most attractive people are the ones that we listen to. The influencers had much more voice than some of the professionals. And so figuring out how to manage that information was really important. But listening to them was, to me, one of the most valuable things. And I would learn more from them sometimes than was on that card. And I would look at that card and I'd be like, did you guys know about this? And and you have this army of people that we could sort of use if we were a little bit maybe more willing to do that.
Network.
I appreciate very much the conversation with the panelists this evening. Obviously, lots to armchair quarterback about the pandemic. As we used to say at the school system, I promise we'll do better on the next one, as we continue to try to navigate how to get through this in the least harmful way and in the most beneficial way. We want to talk about where we are and how to improve some of the impact of the pandemic and some of the things that were lingering or looming there before. I'm Hans Vogel with the Stubblefield Institute this evening, the American Conversation Series on WEPM and WCST.
Welcome back to Post-Pandemic Healthcare, a discussion of growth, stress, and civility, presented by the Stubblefield Institute for Civil Political Communications and WEPM, WCST, the Panhandle News Network. Here's moderator Hans Vogel.
Thank you, Marcia. Thanks for joining us. Those of you at home who are just being part of the conversation, we are on the campus of Berkeley Medical Center, where we have a group of panelists discussing healthcare during the pandemic, some of the lingering effects, and then we got into the topic of how to regain some of the trust that was lost in the swirl of up-to-the-minute information, misinformation, and then conflicting information that came about as a result of some of those factors. I was about to say in studio. At the table this evening, we have Dr. Michael Londner. He is the Vice President of Medical Affairs at Berkeley Medical Center. Jake Meza, who is the Vice President of Ambulatory, Post-Acute, and Wellness for Valley Health. Dr. Woody Moss, a clinical medical ethicist. Dr. Clay Marsh, who is the Chancellor and Executive Dean for Health Sciences at West Virginia University. Mrs. Charlotte Norris, a community health worker with the Partnership of African American Churches. Mike Hassing, the Chief Executive Officer for Shenandoah Community Health here in Martinsburg. And Dr. Kevin McLaughlin, who is the Health Officer for Berkeley Morgan County Health Department and an ER physician at War Memorial Hospital. I think we could spend probably a week-long panel discussion on how we responded to the pandemic, what we've learned, what we haven't learned, how to do better next time. But I think one of the takeaways from our previous conversation was we would need more folks at the table than what we have right here. Tonight's conversation is focusing on healthcare, where we stand today, some of the challenges we face as a community as we look at growth and opportunity for our region, and how not having adequate medical care, infrastructure, staffing is going to affect that. Before we get to our audience questions, really quickly, I'd like to ask this group for any ideas that they have on how to address staffing shortages in the healthcare field and what incentives they think we could offer as a community to attract more providers and nurses to the Eastern Panhandle. Dr. Moss?
And I would really be interested in the thoughts of others. I think this whole travel nurses, travel respiratory therapists turned out to be very counterproductive. I was talking to a nurse who said she went into the emergency department and she had worked in the hospital for years and didn't recognize a single nurse working in the emergency department because they were all travel nurses. The hospital was paying 2.5 times more for them than they would have paid for their own nurses. I think rewarding the nurses who stayed and worked would have been a whole lot better idea. They would have known the culture, known the environment in the hospital, and they wouldn't have had to be paid 2 to 3 times more. So try and retain the people you have, properly reward them.
Mr. Hassing?
So I guess when I was thinking about this, responding to this question, so at Shenandoah Community Health, we have a mission to provide services without regard to ability to pay for everyone, all walks of life, and for those who are uninsured and such. And there is a certain joy that comes with providing services to the underserved population, and somehow we have to help the students, help the nurses, and help the providers find that joy again in providing those services. There's a lot of folks that got, and I know that even now the providers at my clinic are feeling a bit burned out. They're feeling very stressed, as are the support staff. And so, I don't have a silver bullet for it, but if I was able to do something, it would be to try and link back into that joy and service.
Dr. Londner?
So two things in different pathways. The first, a little bit more existential. We very quickly as an organization recognized that the finite game was no longer the game, and the infinite game became the real game. And so, whereas you would walk into the hospital in the morning and figure out what the census is and how long people are going to be there, now it became the first order of business was establishing a just cause. Otherwise, people don't come to work. And the just cause was we are going to save the community. And people need to really believe in that, or there's no point in coming to work. And if you come to work and then you find a bunch of people not from your community doing it for 4 times the cost of half the amount of effort, it's really hard to come to work. The second was to develop trusting relationships, and I'm going to, I think he's still here, Dean Thomas is here, who has, I think, more than anyone, really picked up the torch and carried it for our organization. We'll talk about a few examples of how to bring people back to the workforce. Really bought into the idea that we're going to develop trust by taking those folks and rewarding them for staying, and encouraging people in the community to stay here and train to be in this field. Very important. We then copied successful models from each other, and I think a lot of people did that. And then more importantly, we had the courage to make those changes. And so just as a couple of ideas, we looked at some of the fields that were really lacking, radiology techs, things like that, and they went into the community with school partners, educators, with people who had not made life decisions yet, and said, if I pay for your education, would you come? If I give you a 4-day work week, would you come? If these people have an education model that we can just intercalate you in and we'll pay you while you go, like, what is it going to take to bring you into the field? And then more importantly, what's it going to take to keep you here? And they've introduced, I don't know, 5, 6, 8 programs now in the last year for nurses, for technologists, for medical assistants, for radiology techs, ultrasound, a lot of the support services, we talk about the physicians and nurses, but a lot of them can't do anything unless you're providing them the tools and the data. And so I really champion the question and the idea that people who weren't necessarily providers looked at finding good answers and bringing in a whole new lifeblood of folks. And again, people have been in the industry for a long time. We talked a little bit during the break. The titans who did things the same way forever might not have had the right answers. And so now these are some of the new answers, and they're coming from the youth that are being infused into our systems at the EMS level and at the hospital level.
I'm hearing a lot from everybody about community and culture, sustaining that and creating a place where people want to come to work. I can only speak for myself. We have nurses who live in our neighborhood, and we would cheer them on. I'm sure some folks in the audience may remember holding up signs and thanking them as they came back from a late shift or a double or a triple shift while they were treating people. So it goes beyond just the walls of the hospital, I think, into our community, which we're about to do right now. So we're going to go into the audience. I will bring the microphone to you. If you would like to ask a question this evening, just raise your hand and I'd be glad to come over. Just introduce yourself for the folks at home and then pose your question to our panelists.
Thank you. My name is Sherman Lambert, and I have a question initially for Dr. Clay Marsh and perhaps Dr. Moss, because of his discipline and ethics, may want to weigh in. Dr. Marsh, in response to the moderator's initial question regarding your thoughts of practicing medicine during the pandemic and how healthcare changed as a result, your response was, we never prepared for the requirement. We never prepared for the requirement. Without triggering any medical, ethical considerations, could you share your thoughts on what we should have done or could have done to better the results? And I guess the sub-question would be, not being prepared perhaps could have been an ethical problem, and whether or not the AMA has promulgated any new rules for physicians because of the pandemic.
Dr. Marsh?
Well, thank you, Mr. Lambert, for your question. And a famous philosopher comes to mind, Mike Tyson, who said, everybody's a great boxer till you get hit in the mouth. And I would say that the lack of preparation in retrospect was not done intentionally. And in fact, we were rated as the most prepared country in the world. So the belief going into the pandemic is we would respond best. Our Centers for Disease Control was legendary in managing these kind of issues around the world. But what happened was, just like in Katrina, systems start to break down. Communication starts to break down. We heard from other panelists, the information we were getting was in real time, and sometimes it was changing by the hour, by the day, faster than by the week. And because of that, we tried to reorganize our response team. But inside of West Virginia, we ended up making our own masks, our own gowns. We made our own testing for COVID. We did our own genetic testing. We identified our own variants. So we were very self-sufficient, which is indeed what was required, because in West Virginia, we were late in the line, and big states like New York and California and others that had big problems, they got served first, and that was appropriate because they had big numbers of people. So I think the lesson to be learned here, and people talked about multiple different disciplines, while I respect that, and I think that's true to the greater level, I think we really need to get much more tactical and much more operational, and we really have started to learn from our military colleagues that are in very unsettled situations that are changing rapidly, and where you start to break down barriers between parts of your organizational structure that can feed each other. And we created a team of teams, so to speak, and we called it the Joint Interagency Task Force, and that had a number of different stakeholders, so business stakeholders, hospital stakeholders, long-term care association, primary care association, FEMA, et cetera, all around the same table, and we had open conversations and helped each other. That was very successful, but that was not the way we did business before. So we adapted, and we need to continue. but the ability to adapt most successfully. You know, with the Darwin, he was credited by saying it's not the bravest or the smartest or the strongest of the species that survives, it's the species that's most adaptable to change. And that indeed is a lesson that we have to take out of this.
Dr. Moss?
Yeah. So actually, sir, we did prepare. In the public health literature for the last 20 years, they said don't do what we did. They said don't do extended lockdowns. The CDC said that the pandemic was associated with a mental health crisis of immense proportions in this country. Loneliness, isolation, anxiety, depression, teenage suicide attempts, drug overdose deaths, alcohol use related deaths. Some economists and behavioral health people looked at, if you combined all the factors together, many people reached the conclusion that overall the outcomes from extended lockdowns were worse than if we had not done extended lockdowns. Part of public health ethics is really what we call equity and being fair to all groups. And there were the people who were lower income, who couldn't work remotely because their job required that they come to work. Those were the most disadvantaged by our response to the pandemic, and those groups suffered the most. There was a term I just learned as I studied this area, deaths of despair. And deaths of despair took off the chart in the last few years. So pretty much what people have concluded, and Dr. Marsh is noticing that I have a paper about to come out next month on the topic, which is the reason why I can talk about it, is that, and I'll tell you even what the editors decided should be the pull quote for the paper. The lesson for the future is that extended lockdowns constitute high-risk interventions in which there is a high probability of severe harm to many vulnerable populations. In the face of another pandemic, the burden of proof should be on those who would advocate for an extended lockdown. And there must be a much higher burden of proof on those and high quality evidence that the benefit would substantially outweigh the harm, and such evidence does not presently exist. So, and Jake, I think you even alluded to it a little bit. Americans don't like to be told no. And as it turns out, this is something that the public health literature was very clear about. It referred to what was called forced quarantine before we used the term extended lockdowns as blunt instruments or extreme measures, and that we should do voluntary things, not mandatory things. So, sir, to get back to your question, we were prepared. We just didn't follow our own teaching or wisdom.
And so with that in mind, looking at tonight's topic, that created, I think, some real strain on the system when people did come back for their primary care. They did come back for the treatments that they'd been delaying. Health outcomes were worse because people had delayed or deferred. So now that we stand here with staffing shortages and lack of specialists in our region, et cetera, how do we solve that? Does anyone have ideas for fixing what went wrong with this pandemic? Is this an idea or a question? All right.
Hi, my name is Marshall Wilson. Yeah, okay. So I appreciate you all being here. I really do. Admiral, sir, I can't tell you how grateful I am that you set this all up. Thank you for what you do in our community. I want to let you know that I appreciate the fact that you get out here, you present your perspectives, your backgrounds, you let us all know exactly who we're dealing with. You have a right to know who I am as well, because I'm going to ask a question and I'm going to offer some recommendations. My name is Marshall Wilson. I'm a retired combat veteran U.S. Army infantry officer. Also, I am a strategic and operational planner trained by the United States Army. I wrote, along with two other people, Louisiana's All Hazards Operations Plan after Katrina. We were the ones who sat down and read the after-action review, collected all the lessons learned, interviewed all the people involved, went back over years of data, and made decisions. We made the decisions based on lessons learned, as Dr. Moss recommended. That's what you do. That's how you build your future plans. You can be prepared for future operations. What you cannot do is project every single thing that's going to happen. So what you do is you make your decisions, you make your plans based on principles. Your principles, of course, are founded on your ethic. Not your ethics, your ethic, the thing that drives you, the thing that matters the most. Okay, so if I may, I'd like to give you a little bit of what I picked up during this discussion. Should put my glasses on, I'm getting old. What made me start thinking about military operations was Dr. Marsh mentioned the term triage. I'm not a medical guy, but it kind of pushed it into military operations for me. Dr. McLaughlin referred to the dynamic situation, the changing situation, dangerous things happening all over the place. I'm an infantryman. Yeah, we'll get to the question, I promise. Thank you. Yeah. So the thing is, you pushed me into it got me thinking about this. Mr. Meza, you said that Americans don't like to be told no. The problem with phrasing it that way is you make it sound like Americans are just children who don't like to be told what to do. The simple fact of the matter is, no one has a right to tell Americans what to do. Okay? That's the fact. No one has the right to tell Americans what to do. All right. Environmental factors, once again, the dynamic situation. Yes, sir. Yes, sir. I am a combat veteran. I know about this, and I commanded troops in combat. So what I would like to propose is that you actually bring together people who know how to do what we're talking about. Not just medical people, but people who actually know how to do strategic and operational analysis and build these operations based on lessons learned. Now, I'd like to direct the question, if I may, to Dr. Moss. What is the ethical basis, if any, for extended lockdowns? Thank you.
Well, the theory was that it would save lives from COVID deaths. But what they failed to consider, the CDC and those involved in the planning, was all the countervailing or other things that it would cause. And as I went through that discussion of the psychological, the economic, the educational, I didn't even mention the disaster that occurred to our school children from extended school closures. So those are the harms, okay? And that's I like this idea of bringing together people who are good at strategic planning, who can look at the evidence base and try and figure out the next time around, what can we do instead? I think that's a great idea.
Yeah, I think the next pandemic, it seems that there's a group. Do you have comment on that, Dr. Marsh? Sorry, reach for the microphone. Okay.
I was just moving it back.
Excellent. Gotcha. Okay. I have this gentleman first, and then I'll focus.
Well, good evening. My name is Doug Anderson. I'm just a concerned citizen. I'd like to talk about the incivility in our healthcare organizations. The question is, was that a pre-existing condition, or was it exasperated by the pandemic? And what's your plan to reduce or eliminate anger, hostility, incivility, and violence in our health and human services?
All right. Who'd like to start on that one? No one's jumping for that. Dr. Marsh?
I will take a modest swing at this pitch that is placed low and outside on the plate. So, I think that, and Dr. Londner talked about this, healthcare in our country is in an existential crisis. When you look at the amount of money we spend and the outcomes we get, we spend almost twice as much as any other country, and our durable outcomes are last of all westernized countries. And our lifespan is going down while other countries in comparable areas are going up. And in fact, a child born today is less likely to reach 20 years old than a child born 2 years ago, which is the first time we've seen that in the modern history of our country. We have an editorial in the New York Times where a physician wrote a story that was published that said that they had a moral dilemma in healthcare because of the corporatization and all this. Now, healthcare people aren't evil. People are all trying to do the right thing. But the challenge is that we are at a moment where healthcare in other countries that tends to be more centralized and free to people is not as accessible, available as is here. And the healthcare workforce is under a lot of pressure, as we talked about. So I think that the incivility that you talked about, the anger, etc., is really in many ways because we've gotten away from the roots of what we do, the roots of our profession. And Mike talked about finite and infinite. I like to read a lot, and I'll be quick. I'll be done here in a second. I like to read a lot, and one of the books I really like is a book by a mythologist named Joseph Campbell. And he wrote a book called The Hero with a Thousand Faces. And he talked about the hero's journey, which is the metaphorical journey that all of us take, going from the finite self to the infinite self and reemerging and returning home as the prodigal child, etc. And I think healthcare is going through that right now. And for many of our providers, we've gotten away from our sources because the root word of health and heal and holy and holistic mean whole, W-H-O-L-E. Community means together as one. E pluribus unum means out of many one. So we need to get back to reconnecting. And that's why our healthcare workers need to be cared for as well, because ultimately many of our healthcare workers are as sick as the people they are seeing. And that is the crisis that I think is the most threatening to our futures.
Thank you, Dr. Marsh and Dr. Londner.
I also tip my toe into the water of answering this question because it seems to be a little bit difficult, but also extremely important. There's a number of folks here, I think Leslie's in the audience, and we talk about I guess the easiest way to describe it is that there is a confrontational relationship that is formed between patients and providers at all levels at this point. And so I don't know that it was necessarily done on purpose. It seems to have evolved, and once it started picking up momentum and rolling downhill, it got faster and faster. And so the fact that you showed up at 3 a.m. And there's not anything wrong with you doesn't mean I should be angry with you. This is my job, and I'm supposed to be here to help you. And you thinking that you need help means I should give that to you. And we sort of lose perspective of that the more that's heaped on the providers. And so just as much as I think that we need to address this from the patient care side, patients also now feel very comfortable to bring weapons to the department to threaten providers. We have assault in our department daily at this point. And so we all need to look at that relationship and figure out how to get back to some basics of being, I think, just better to each other as humans. And so we now involve patients in all of our advocacy programs in the hospital. We have patients who sit on all of our review boards. We even have a patient that's part of our emergency department PI now that can give a perspective that's not medical. So I think we've said them all before, but it's really just doing those things, infusing those things into the fabric of what healthcare is.
I'm going to have to let that be the last word because we do have a hard stop coming up. I apologize, but thank you very much to our panelists. I thought 90 minutes would be enough to solve it, but we'll have to come back. Thank you to the Stubblefield Institute at Shepherd University. Thanks to WVU Medicine, and thanks to Valley Health for sponsoring this event. Thanks to everyone at the Panhandle News Network. I'll hand it back over to Ashley Hurst now.
Right. First, please join me in thanking our panelists for being willing to handle this very sensitive topic in a public forum. What a great discussion we've been having. I'm really disappointed that we do have to draw it to a close now, as I know we have many more questions that have come in via Facebook and email, and many questions in the audience that were not asked. So the question was, can we continue to have this discussion off the air? And that is up to our panelists. It looks like we have consensus that we can continue this discussion. It's an incredibly important one. All right, and then I'm going to hand it back over to
WEPM Martinsburg and WCST Berkeley Springs, a WVRC media station.